we present our experience of high-resolution microultrasound imaging for bladder cancer. The microultrasound has previously been tested with regards to prostate cancer. Compared with the MRI, it gives very interesting results. MRI scans for bladder cancer are becoming more common and may provide accurate information that can help improve patient care. This said, MRI has drawbacks, such as its high costs, it being time-consuming, and it not being available in all centres. The aim of the study is to therefore test the hypothesis that high-resolution microultrasound assessment may predict the pathological stage, discriminating between NMIBC and MIBC. Microultrasound imaging was performed before TURBT versus in-block TURBT, or radical cystectomy, by Exact VU system with a 29 MHz side-fire transducer. Here you can appreciate the hardware and software that have been used to store the images. This is a 29 MHz side-fire transducer with a cover bag and the guide needle. This is the organization of the operating room, where you can see the ultrasound device on the left side, the endoscopic screen in the front, and the patient placed in a lithotomic position. The bladder was previously emptied by catheterization and afterwards filled with 50 centimeters cubed of sterile saline solution. In the female population, the transvaginal access offered a sagittal section of the bladder. The bladder is of triangular shape and its contents appears to be anechoic. When the transvaginal probe was laterally rotated, we found some artifacts due to anechoic reverberation. In the male population, the ultrasound is performed transrectally. The study endpoints have been organized in a multi-step process. The first step was to investigate the feasibility of the procedure, defined as the possibility to access the bladder window. In particular, under the setting, we investigated the differences between male and female populations, considering their different anatomy. The second step was to define the microultrasound features of a normal bladder wall. We tried to report a normal layer representation, including the mucosa, muscle, and perivesical space. We defined a normal urothelium as one in which all the layers were adequately represented and no mass or interruption was noted. The third step was to describe the bladder wall lesions, splitting images into NMIBC or MIBC. The fourth step was to correlate the microultrasound imaging with a pathological outcome. In this video, you can see two examples of a normal bladder wall, where you can appreciate the single layers. From in-out, they are mucosa, submucosa, muscularis, and serosa or adventitia. These two video clips represent the anatomical endoscopic view of the bladder wall, with the layers that we have seen previously. With microultrasound imaging, the bladder wall appears as a three-layered structure. The first layer represents the normal urothelium. Here, you can see the second layer, the lamina propria. In between the two aforementioned layers, the stroma appears. At the end, we have the last layer, the detrusor muscle. This lady is affected by NMIBC on the bladder neck. You can appreciate the endoscopic view, which clearly shows the lesion. Two surgeons are taking care of the procedure. The first one, on the right, works on the endoscopic view, and the second one, on the left, on the microultrasound view. The transvaginal probe is used by the second surgeon that is following the procedure on the screen placed on the left side of the patient. The microultrasound showed a bladder wall tumour emerging from the bladder mucosa that was heterogeneous, hypoechogenic. In NMIBC, we found that the hyperintense epithelial line is disrupted focally in the region underlying the tumour, but no muscle infiltration is present in this case. After the formal cytoscopy, the first surgeon performs in-block transurethral resection of bladder tumour of the lesion using the Collins resector. The lesion is delimited on its right and left side, and it is completely resected in the central part. At the end of the en-bloc procedure, the specimen is integrally removed. There was a strong positive correlation between the microultrasound imaging and the pathological findings. The anatopathological report confirms an NMIBC at the level of the bladder neck. In MIBC, the characteristic three-layer structure is missing. The lesion presents heterogeneous cauliflower, smudgy, or mottled, bright echoes. The pathological sample confirms the muscle invasion. This table shows of our results. 23 patients have been selected to assess the use of microultrasound for staging of bladder disease. 12 males and 11 females were studied. 14 patients were staged via echography as having a non-muscle invasive bladder cancer. In all these patients, a histological exam confirmed the first echography-based diagnosis. In 7 of the patients, the echography-guided diagnosis of muscle-invasive bladder cancer was found to be, according to histological examination, correct in 5 cases and erred in 2 cases. These last 2 patients showed of having non-muscle invasive bladder cancer. In 2 patients, echography-based staging was made impossible by the poor visibility of the lesion. These 2 cases involved superficial tumours located in the anterior wall and the dome of the bladder. These preliminary results show that high-resolution microultrasound depicts the normal anatomy of the bladder wall. It detects bladder tumours and it can discriminate NMIBC from MIBC with a strong pathological correlation.